Hi, and welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor at JAMA Network Open.
And I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along, send us your questions or comments at JAMA Network Open on Twitter, or you can comment in the comment box under the video on Facebook Live or YouTube. So today we are talking about the association between preoperative obstructive sleep apnea and preoperative positive airway pressure with postoperative intensive care unit delirium. And we've got first author, Dr. Ryan King. Welcome, Dr. King.
Hi, thanks for having me.
Great. Really glad you could join us. So tell us a little bit about yourself and why you did this study.
Sure. So this comes out of an attempt by our department at Washington University to use routinely collected preoperative anesthesia assessments to see if we can answer some clinical questions. So our department has a long interest in postoperative delirium. The senior author, Michael Avedon, does a fair number of randomized trials on interventions for delirium, and there's just not been a lot that we can do that seems to be really modifiable to prevent postoperative delirium. Simultaneously, our department also had a strong interest in reducing complications associated with obstructive sleep apnea. So in 2012, we started screening almost every patient in our surgical ICUs for postoperative delirium with the CAM ICU instrument. And in 2013, we started screening almost every patient who went through our pre-anesthesia clinic with the Stop Bang screening questionnaire for sleep apnea. Many of those patients who would screen highly would get referred for formal sleep studies. And we also just started asking every patient about whether or not they had sleep apnea. We collected so we used data that was, like I said, routinely collected. So these anesthesia assessments were designed to help the providers, day of surgery, mitigate risks and to plan their anesthetic and not to be a research instrument. But we think that they're relatively thorough compared to, for example, administrative data where lists of diagnoses are often really incomplete, that at least it would be unusual for the anesthesia clinician to not include the major risk factors that would be useful for their colleague to know. So we had data from 2012 to 2016. We had an unexpected loss of sample size related to a change of our EHR. So when we switched to Epic in 2018, our informatics setup was no longer able to track some of the delirium assessments that had been done. So we ended up with a somewhat smaller sample size that we wanted, or that we anticipated. Kind of interestingly, we found that among patients admitted to the intensive care units, that the rate of postoperative delirium at any point in the immediate postoperative course was actually slightly smaller among patients who had either diagnosed preoperative obstructive sleep apnea or just high risk for postoperative obstructive sleep apnea based on their Stop Bang questionnaire. And we looked a little bit further into that because there's a lot of potential bias you could imagine where, so for example, patients who have correlates of obstructive sleep apnea might be more likely to just be admitted to the ICU. They may be offered less invasive surgical procedures. And so we used those questionnaires to create pretty rich set of adjusting variables. We also were able to extract from our administrative data the address for each patient. And so like most clinical studies, we don't have great socioeconomic data that might be helpful. We were able to look for location proxies based on census data and American Community Survey data. Including all those potential adjusters in a kind of complicated method called Bayesian additive regression trees, we found that once we adjusted for all those things, that protective effect of obstructive sleep apnea really went away, that then there was no difference between the two, which was a little surprising to us. Additionally, we had set out looking to see because our hypothesis was that sleep apnea would increase the rate of delirium, that patients who were adherent to positive airway pressure would have lower rates of postoperative delirium, which makes some mechanistic sense in terms of avoiding postoperative hypoxia or CO2 retention, that might help reduce delirium. we found very little evidence for association in that, although the statistical certainty is a lot lower, because it turns out that many of the patients just did not answer the question about whether or not they used sleep apnea, and so we had a lot more missing data for, they didn't answer the question about whether or not they used positive airway pressure. And so we had a lot more missing data for that analysis and just weren't able to reach firm conclusions. The credible interval bounds that we got were reasonably tight, that we did a lot of sensitivity analyses, and no matter what, we bounded an increase of risk of less than 5%, and it's actually centered right at 0. So one of the advantages of these really large secondary data studies is that you end up with small amounts of statistical error, and the error that's left over is mostly bias study design type things that are a little bit harder to quantify. That's sort of the short version of where we went, and I wanted to talk a little bit more about anything that you're interested in. I know we talked a little bit before the call about some of the Bayesian interpretation stuff. I will point out, so we did a couple of methods for doing this adjustment that when you have this large number of adjusters, fortunately it's a large sample, so you can get away with that. That this method looks for so regression trees are a method where you look for dividing any input feature, any of the adjusting variables, somewhere along it into higher and lower, and then does that improve the classification of the model. And BART looks at thousands and thousands of those trees. It has a prior for proposing what splits to use and for adding and removing future splits. So you can adjust in a completely non-parametric way. So it doesn't assume any sort of like linear functional form. It allows interactions that can be really deep. It's one of the higher performing methods in terms of producing low bias estimates in causal inference contests that are held from time to time. It does have the disadvantage in that the outputs of it are a little bit harder to understand. So you get a credible interval out of it because it's a fundamentally Bayesian technique. In this case, it's almost backwards. So normally we think of Bayesian intervals coming from a prior on the parameter that we're interested in, and then the data, and then you get the posterior. But in this case, so the prior is on how you propose this complicated adjustment model. And this method was partly heuristically guided and has been guided based on experience that this method of proposing adjusting models seems to work really well in practice, and so we think it seems to represent our beliefs over a large collection of what causal models can look like. We did also do some traditional frequentist methods like propensity score matching and such, and got basically the same answers with that. And it's usually the case that credible intervals coming out of BART look very much like confidence intervals. They don't have to be, but it usually is the case that they're pretty close.
All right. Yeah. Well, there's a lot going on. I mean, I think, some of the basic stuff that, I found even with the limitations out on the data, with the change in the EHR, you still had 7,800 patients, and that's with exclusions, because patients only go into the ICU after surgery, not spending too much time in the ICU before surgery, patients who didn't have delirium beforehand, so there's all sorts of trimming of the data there, and still nearly 8,000 patients, which is pretty impressive. It does
a little bit of a generalization issue in terms of we did take out a lot of patients. So, for example, patients who had neurosurgery are functionally excluded from this. That it turned out our neurosurgical ICU just didn't do delirium assessment very much during that time period, or they did it in a very targeted way, which we felt that including them would increase the risk of bias more than it would help. But as a result, you can't really. I suppose you could say it's possible that there's some association only in neurosurgical patients. It just seems kind of unlikely.
Right. Yeah. Oh, before I forget, we've got a couple of viewers, Rowan Kara and Mohammed Al Khalifa, who've joined us. So welcome. We're talking about obstructive sleep apnea and post-ICU delirium. Some of the other things I found interesting too was, about 1 in 5 patients in your sample had previously diagnosed sleep apnea, and then an equal amount had identified on the screen but hadn't been diagnosed beforehand, which is interesting because sleep apnea. I'm not a sleep doc, I'm not an anesthetist, I'm an ER doc, and it's just interesting to me how there's got to be a ton of people. Everybody wishes they sleep better, and there's just got to be a ton of undiagnosed sleep problems that we can probably intervene on a lot.
Yeah, and as I mentioned at the beginning, a substantial number of those patients were referred, but it depended on how far out they were from surgery when they came into anesthesia clinic. So if you're coming into clinic the week before your surgery, there's no way you're going to get a sleep study between now and then. So not really an option for you. And we don't even have good data in our system on who got sleep studies because most of those would have been done outside our system. So we would need we would need data from their billing administration in order to really be able to say that. That was part of the justification for why we were interested in sleep apnea, because it has a really effective intervention available for it. And we also think that it's wildly underdiagnosed in a lot of parts of our community here in St. Louis.
Mm-hmm. And was there I think in your intro you talked about this, was there some prior observational data that suggested there were higher rates of ICU delirium in patients with sleep apnea?
So there have been a couple of studies to suggest that, none that were coming out of our institution specifically. There, as I mentioned, so some good mechanistic data that all the things that sleep apnea predisposes to are known to predispose to postoperative delirium. So just disrupted sleep architecture in general, hypoxia, those are all clearly related. But there's also things that perhaps reduce delirium that go along with sleep apnea. So, for example, many physicians believe that patients with sleep apnea shouldn't get as much opioid as people who don't have sleep apnea. So one of the things we tried to look at was whether or not those patients received less opioid intraoperatively. There was a difference. It didn't appear to explain the association. There's lots of potential downstream changes that go with a known sleep apnea diagnosis as well.
Yeah. And you've kind of combined a couple of my favorite things, such as there's face validity, some good plausible reasons why, as you're saying, sleep apnea could be linked to delirium, and then using data to kind of refute that hand waving physiology is always nice. And also, I think we all agree we should be publishing more negative studies. I can't tell you how many times I hear people say, this study would be, or not this, but an abstract study would be more interesting if it were positive, but it's nice to present negative data. Oh, we were concerned about this, and turns out we're okay. Yeah,
for sure. I think that part of it was having spent a lot of work to get this data ready, not just going to completely give up on it. It does certainly make it a little bit more challenging to draw people's attention to it. And there have been some other high-profile studies recently that looked at sleep apnea and postoperative complications other than delirium, and had notable associations. So we certainly are interested in continuing to look at sleep apnea and postoperative complications in this cohort. It just is. It looks like it's not going to work out in terms of being the silver bullet to reduce our ICU delirium burden.
Right. And then, I think also just delirium I think it's good that it's gaining more attention recently. I know we've done some quality initiatives in our ED, looking at delirium in the ED and recognizing it, because I think it's easy to come from a position like, oh, it's just one of those things that happen to people in the hospital, but it's basically brain failure, as one of my colleagues put it. If somebody's creatinine went up to, shot up to 4 postoperatively, no one would be like, their kidneys will be fine. It's just one of those things that happens.
Yeah, and unfortunately, so you can view this as unfortunate or fortunate, but I think that is just good clinical medicine is all that we can really offer, to be very careful to not give patients who are at high risk or who have delirium additional sedating medications that they don't need, not disrupt their sleep schedules unnecessarily, that it's a lot of basic things that you have to do right. And obviously we're still searching for therapeutics that are effective, and there's some therapeutics that look like that have some signals of efficacy. But it's just hard work in all our critical care environments to ensure that patients can have their can have what they need to recover, even though that's both inconvenient and difficult for us. So, for example, to provide critical care level monitoring without disrupting someone's sleep schedule, it's very hard.
Mm-hmm. And, the last thing you just said, that just sounds so familiar with what we've been talking about with COVID recently, where, it's so easy or tempting to want to jump to things like, ECMO or fancy drugs or other things. And we keep hearing the message that it's fundamentals of good critical care, taking good care of patients, doing the fundamentals well, which, isn't as exciting. It doesn't get, headlines and White House press releases, but it's the, it's the blocking and tackling. It's the important stuff.
Yeah.
All right. Well, I think we've actually gone over our time. Any final thoughts?
I think I said my piece on it.
Right.
Thanks for having me on the podcast.
Great. Well, I appreciate you coming on, and thanks for doing the good work. Keep it up.
Thank you.
All right. Great. Well, thank you. We are going to move on to our next paper, if I can figure out my computer here. And next up, I think, Angel, you've got the first one, right?
I do. It's the Association of Post-Traumatic Stress Disorder with Mental Stress-Induced Myocardial Ischemia in Adults After Myocardial Infarction. This is by Lima and colleagues. And this was a study that was trying to look at the association of PTSD with mental stress-induced MIs or myocardial ischemia, I should say, after among individuals who survived an MI. And so this was a cross-sectional study of about 300 patients within a university network system. The patients were all those that had an MI within the previous 8 months. Really interesting. The thing that I actually found very interesting about today was the sort of the demographic breakdown of the patients that were able to be included. So 65% were African American, 48% were women. And the study found that patients with PTSD had higher rates of ischemia with mental stress than those without PTSD, so 27% versus 14%. But that there was no difference in conventional stress ischemia. So sort of an interesting, I had actually never sort of heard this term mental stress-induced myocardial ischemia. So that in itself was interesting, but I also thought it was sort of nice to see a pretty diverse group of patients included in the study.
Yeah, it was really interesting. I mean, some of the things, just that 1 in 6 patients after MI had PTSD is just kind of, I think, the mental health is, we kind of often overlook it in a lot of our clinical situations. And that's a meaningful outcome for a lot of people. And then what was the other thing? There was some discussion in here too, where they, because one of my thoughts was, is a reverse causality, is that people who have worse MIs are more likely to be, pushed into PTSD. And they said, based on the kind of clinical markers they had, there was no reason to suggest that they should. And if anything, the patients looked pretty similar otherwise. So it's pretty interesting. And it's also, I don't know, it's always reassuring to see that, mental health issues, serious problems like PTSD, have physiologic bases. It's not, this isn't just, all in your head.
Yeah, no, I agree. I definitely agree.
We've got Ali Yadiram, who's joined us. Welcome. We're going to move on. What's our next paper?
So this is called Prevalence of Antibiotic-Resistant Pathogens in Culture-Proven Sepsis and Outcomes Associated with Inadequate and Broad-Spectrum Empiric Antibiotic Use. I have to give a shout-out. I noticed today that the first author was Chana Rhee, and one of the other authors was Michael Klompus, both from Berlin Women's, where I used to be. So that was kind of fun to see them. But this is a really interesting study also. The objective was try to essentially describe the epidemiology of antibiotic-resistant pathogens in the U.S. and the outcomes associated both with undertreatment and overtreatment in patients with culture-positive community-onset sepsis. So 17,000 patients from 104 U.S. hospitals with culture-positive community-onset sepsis were included. They found 16% of patients died in the hospital. The most common pathogens that were isolated were E. coli, Staph aureus, and Streptococcus. Streptococcus species. So there were about 15,000 cases where antibiotic pathogen susceptibility could be calculated, and they found of those cases, most received adequate empiric antibiotics, about 80%, which is pretty good. They also found that resistant organisms were actually pretty uncommon. So MRSA, 11%, VRE, 2%, ESBLs, only 0.8%. But that empiric therapy targeting resistant organisms was actually pretty common. So in about 11,000 of the 17,000 cases, so 67%. Primarily, these antibiotics were vancomycin and anti-pseudomonal beta-lactams. And so basically the kind of overarching conclusions are that most patients in this cohort with community onset sepsis did not have resistant pathogens, but received broad-spectrum antibiotics frequently, and also that inadequate and broad-spectrum empiric antibiotics were both associated with higher mortality. So it's, I think it's sort of an interesting discussion because I think there is always this kind of tension between the two. So it was sort of, when you're presented with somebody with sepsis and just trying to figure out the right empiric regimen. So it's kind of nice to see this data support that tension that we all feel.
Right. Yeah. And I feel like I had mixed feelings on the results here where, some degrees, yeah, it's great. We were pretty good at coverage. It was also like 20% of patients didn't have good empiric coverage, which is not a small amount. And the fact that there were, there's basically associations of worse outcomes in both directions, like you said. I think it's pretty clear if we're not covering the bug that the patients have and they're septic, that's bad. But also the patients who got broader spectrum antibiotics than they ended up needing, which is a lot easier to find in hindsight, did worse. I'm curious what your thoughts are as an ID doc. First, we've got Aki Badboy and Susana Herrero have joined us. Apologies for my pronunciations. So I'm curious, do you think this is, they're getting harmed because they are getting like the side effects like C. diff from the antibiotics, or do you think it's more just that people who were prescribed broad spectrum antibiotics were, that was just a signal they were sicker and so they're going to do worse?
Probably both. Yeah. I mean, these days are always so hard, right? Because you're exactly right that, the patients that are sicker tend to receive these sort of broad spectrum antibiotics, but it is the case, and this is sort of anecdotal, that the other sort of spectrum also happens. It's not really the spectrum, but that these patients are having lots of complications too. So I think it's tough. I think it's just really tough. And I can't remember if they talked about this in the discussion or if this was just a thought that I had, but, I think it also supports like diagnostics are really important, and being able to get that identification of an organism and susceptibilities is important too, to be able to really target appropriate antibiotic use for patients in both directions.
Mm-hmm. Yeah. I was trying to find, I'm searching through the PDF now, the rates of C. diff were pretty high with, I think, a 26% increase in odds of C. diff with unnecessarily broad antibiotics, which is serious harm that we know about. That's an odds ratio. It's not, that doesn't mean 26% of people get it. It's just an increased risk. But it's tough, and this stuff can be really tough to balance. I mean, the taking care of the sick patients in front of you versus the antibiotic stewardship. And the antibiotic stewardship, that's not just this abstract concept of resistance, but also potential direct harm to the patients.
Definitely.
It's really tough. I mean, I think one of the silver linings of the I think runaway Zithro excitement right now is we might finally be done with azithromycin.
I don't know. It may find its way back again.
Yeah. I don't think we're done with it yet. I mean, it's out of the CAP guidelines, which is good. But all right. So we've got one more. We've got one more paper, and this is, again, to be a little Bayesian, this one goes right at my priors. So we've got analysis of ingredients of supplements in the NIH supplement database marketed as containing a novel alternative to anabolic steroids by Cohn and colleagues. So this is great. We've talked about supplements before. We know supplements in the U.S. are regulated really terribly. A lot of them don't have what they're supposed to have or what their label is having. A lot of them have pharmacologically active ingredients that they're not supposed to have. either stuff that's not listed on the label or things that are frankly illegal. So this looks at a relatively, I guess, novel supplement, 5-alpha-hydrolaxogenin. It's a synthetic plant steroid analog that's basically promoted as an anabolic steroid. And it's according to I didn't do a lot of background, I'll be honest. According to the paper, the NIH thinks it's probably illegal in the US, which was an interesting phrasing. But it's definitely used in Russia along with none of the other things. So they basically, what the researchers did was in November of 2018, they tried to purchase this 5-alpha-hydrolaxogenin in supplements from 6 different suppliers. First of all, they could only get it from 4 of them. One of them was out of stock and another one had discontinued. I guess it being discontinued is a good thing because, this is one of those unregular or probably illegal and probably harmful supplements. Of the 4 that they found, there were 16 different ingredients that basically did chemical analysis of them. 38% of them couldn't detect the active ingredient, that 5-alpha-hydrolaxogenin, which I'm going to keep saying probably incorrectly. So 38% of them didn't have it that they were supposed to have. 30%, only 30% had the labeled amount of what they said they had. And when you look at all the chemicals they said they had, or all the pharmacologically active chemicals they ostensibly had, they had between less than 5% and up to 109% of what the label amounts were. Again, only one had the ingredient, the 5-alpha-hydrolaxogenin, and there were a bunch of other things like, again, I'm going to pronounce these all wrong, but phenibut, rimistane, and a bunch of other, basically other types of potential anabolic steroid analogs. Apparently a bunch of them are used in Russia. I don't know if off-label is the right word, 7-keto-DHEA and a couple other things. And the table is too much going on and too small to show on the screen now. But if you look at the paper, it's really interesting because there's just all these different ingredients. Most of the comments are either these aren't detected and it's supposed to have it, or it's an active ingredient that's not declared. Just what we know about supplements, just they don't have what they say they're supposed to have, and they do have things they're not supposed to have. So buyer beware, don't buy supplements.
Yeah, and I liked the conclusion. One of the conclusions also that this database isn't, I think they said the database isn't capturing everything that's in it. I mean, obviously that's kind of the point, right? That the labeling is incorrect. It is interesting. Because I think our society is sort of really into supplements. And so it is I enjoyed reading this for that purpose, just to realize exactly, as you said, we have to be aware of exactly what we're getting or what we think we're getting.
Right. Yeah. And just to expand on what you said, this is the NIH database of things that are reported, or when we know there are problems. It's kind of I think there's a similar FDA database for supplement issues. But there's only so many supplements that are actually listed in the NIH database, and only so many that have potentially cause harm in the FDA database. It's just this terrible mix of just haphazard trying to police, chasing after it. As you said, some of these are out of stock or discontinued, so the target keeps moving. It's kind of typical gray or black market stuff. It's just supplements bad. We spend way too much money on them. I mean, look how much people are talking about supplements for COVID now. Sorry, I keep tying everything back to COVID because, that's everything now.
Yeah.
But it's just fascinating. And people, think it's just the disconnect between where the science is, where the regulation is, and where public opinion is on supplement is terrifying, which is why I'm harping on it.
To put it. No, that's a really good way to put it. That's exactly right.
Thanks.
I think.
Yeah. Well, thank you. I appreciate it. All right. So that brings us up to just the half-hour mark. So we'll close up there. Thanks for joining us. Of course, you can get these papers and more at JAMAnetworkopen.com. Everything is free and open access. So we've got new papers coming out every day or every weekday at 10 a.m. Central Time. Join us next week, April 28th, Tuesday, 3 p.m. Central Time. We will talk about some more papers. So thanks for following on. Take care.
Oh, bye.